Professor Giles Katamole is also assistant professor in our unit. So he's now a consultant in emergency medicine at King's College Hospital, NHS Foundation Trust in London in the UK. He's also an honorary associate professor of our unit and an honorary associate professor of the University of Rwanda in Africa. He worked there for several years, and he's contributed greatly to teaching there, including trauma and other resuscitation work. During the time he was in our unit, he led a lot of different interesting projects, some visiting primary school students, getting a lot of measurements, and they were very well published and were very useful information. So without further delay, let me hand over to Giles. He's going to talk to us about teaching EM in developing regions. Thank you, Giles.
Great, thanks, Kevin. Hopefully that screen is now visible and you can hear me. Great. Good way to start. So yeah, thank you for the introduction, Kevin. Yes, I'd like to talk about teaching emergency medicine in developing regions. As Kevin said, I have just got back from Ghana. This was yesterday or the day before. I lose track of time. I have literally just arrived back on the plane overnight from Accra. If you're not sure which one I am, I'm the fourth from the right. That was a meeting with the Ministry of Health and their College of Physicians and Surgeons. We had a great time advising them on their EM curriculum and training in workplace-based assessments for their emergency medicine residents. And Ghana is probably the sort of typical kind of country that you might think of when you're thinking developing regions. What do we mean by developing regions? The map here is IMF and World Bank derived classification of developed in blue. It's difficult to see, but Hong Kong is just in blue there. And then developing in yellow and least developed in brown. Now that's relatively out of favor. It sounds a little bit us and them. But it's still a very useful marker. We could talk about high income, middle income, low income countries. We could use the Human Development Index, but whatever we use, much of Asia is in that developing or middle income bracket. And of course, even within countries that may be a higher income or middle income, there will be regions in those countries that have limited access and resources. So that's what we're talking about now, developing regions, not so much rich countries that haven't yet developed EM, but poorer regions in countries where we're trying to help them with their emergency care. So that's the focus of this talk. And what I want to do is just go through a few questions. So why bother teaching EM in those kind of settings, in low resource settings? What are we teaching? How are we teaching it? Where are we teaching it? And who is teaching whom in those settings? So let's start with why. This will take up probably most of where we're going with this. Why teach emergency medicine in low resource settings? Isn't emergency medicine quite high tech? Isn't it something that really you can only do if you have lots of resources? Well, let's just start with, I think, a very simple answer to the question why. Because we should. We just should. It's all about equity and justice in healthcare. 3 years ago now, the World Health Assembly passed Resolution 7231, which called on governments to ensure universal access to timely and effective emergency care. And that would involve gap analysis and providing training, evidence-based training, or rather training in evidence-based emergency care. Now, there was a 2-year timeline. You may remember something happened in between May 2019 and 2 years later, and that was COVID. So I think the response to this has been lost in COVID a little bit. But what it did do was it embedded emergency care in global health. It made emergency care effectively a right for everybody. And so if that is the case, emergency medicine training is needed. So it's all about equity, because we should, but it is also because, well, just health is global. I alluded to 2020 and COVID. It was true before COVID. It's going to be true after COVID, but COVID made us so much more aware that there is a need for global emergency medicine responses, because we all benefit. No man is an island, said John Donne. And no country is an island, not even Hong Kong or Britain. We have to share in the task of equipping all of us to meet the challenges. And it's not just COVID. There are huge global challenges. So it's all about that mutual benefit. It's all about equity. Now, that mutual benefit, we did a study at the Royal College of Emergency Medicine, published a year ago in EMJ. And these were the kind of things that the individuals got out of it. So there's obviously a national benefit or international benefit, but there's also benefit for those individuals who are involved in training. They develop their own teaching and clinical skills, their cultural awareness, their leadership, and maybe it sounds quite, maybe almost selfish, their own appraisal and CPD and their career progression. But the point is, there will be these kind of mixed motives for people who are involved in emergency medicine training globally. And I suspect many of you have been involved in training or providing healthcare courses in many of the countries around Hong Kong. I remember when I was working there 10 years ago, I think I went on trips to Kunming province, to Laos, to Philippines. I've since been back to Kalimantan, Burma border, and I'm sure many of you do as well. I know people were going to Vietnam. There's a lot of this work going on, and many of you will have experienced those benefits from doing it, as well as the benefit for them. So whatever is the reason for doing it, we're doing it. But why specifically emergency medicine, not just the public health, the basics, the infectious diseases that kind of is more obviously needed? Well, just to reinforce that why it needs to be global emergency medicine, we need to show that there's both need and benefit. So first of all, the need. Well, this may be obvious to many of you. Some of you may not be aware just how big the burden of emergency need is. This is data from admittedly some years ago. Injury, trauma kills far more than HIV, AIDS, TB, and malaria put together. One trauma death every 6 seconds. And it's not just trauma, it's emergency medical diseases as well. So this slide is for deaths. You get a very similar picture for disability adjusted life years. Globally, over half of deaths are due to emergency medicine disease defined as that which would be amenable to good emergency care. But if you look at the slide, the top row is the global figure. 51% of total deaths would be amenable, I'm not saying preventable, but amenable to good emergency care. But that figure is much higher in low income settings. It's nearly 60%, whereas in high income settings, it's only 40%, which would imply to me that if there's anywhere that we should be providing good training in emergency medicine, it's in low and middle income countries. This was an infographic from the African Federation of Emergency Medicine, which summarizes some of those same points, that injuries kill more people than HIV, AIDS, malaria, and TB, that half of deaths, in fact, more than half of deaths in low and middle income countries are due to causes treatable by emergency care. But in addition to that, these are in areas where many countries have no hospital with an ED, many health workers, most health workers have had no emergency training, and there may be no formally trained paramedics. And that is going to be true of certainly some areas in Asia, even if not whole countries. There will be areas where there simply are no paramedics, no EMS, no emergency department, and certainly no emergency medicine training program. So this is true to a lesser extent, but it is still true in Asia as it is in Africa, in Asia Pacific as it is in Africa. So there's a clear need and a need for good emergency care and training in it. But what's the benefit? Does it work? Does it make any difference? Well, unfortunately, there isn't much good outcome evidence for training in emergency medicine, but I'll just give you a couple of examples. The ETAT course, the Emergency Triage and Treatment course, was introduced into a Malawian pediatric outpatient department. They didn't have an ED in those days, 2006. Some of you may know that course. It's a WHO-sponsored course, and this was published in their bulletin. It effectively more than halved mortality in that effectively emergency reception outpatients department after introducing a basic triage and treatment course. And that's been reproduced in many places. But what about emergency medicine training itself? This paper came out of Kigali, where I was program director on their emergency medicine training course. I was there 15 to 17. It was a new residency program that started in 2013. Their first graduates graduated in 17 or 18. This slide shows a comparison between mortality before the program started. So on the left, 2012 to 13. On the right, it was in the middle of the program, 2015 to 16. So there's a 3-year difference. The red column are deaths in the ED. The green column are deaths on the wards, in hospital deaths. And the grey column is overall hospital deaths, ED and wards put together. Just looking at that red figure, I know it's difficult to see the numbers on the slide. Mortality fell in the ED from 6 to 1%, with quite tight confidence intervals. And the figure for overall hospital was mirrored that fall. A hugely significant difference. That was also clear that the mortality among cases treated by EM residents, those who are in the training program, was similarly only 1.3% compared to 6.6% of those who were treated by the medical officers, those who were called general practitioners, but were those who had no emergency medicine training. So we saw a huge reduction in mortality in the ED, and we saw it was very clearly associated with those who are actually in the training program, which was really encouraging, and really encouraging for those of you who might be involved in initiating training programs in emergency medicine in Asia Pacific. But I said earlier that the WHA called on governments to have good evidence-based emergency care. We need to be teaching the right emergency medicine, not just the emergency medicine that is appropriate in our high-tech, high-resource settings. Now, some of you may know this paper. This is now quite old. It's 10 years old. This was Maitland's paper called FEAST. This was a study of a few thousand, 3,000 children with sepsis. About half of them had malaria, but half did not have malaria, but they were all septic children in East Africa. And they were randomized to either albumin, saline, or no bolus. And what I mean by the bolus is the standard APLS 20 mils per kilo that we normally give. That is what our APLS teaching still is. They were looking really for a difference between albumin and saline, I guess, but they had the 3 groups, and there was no difference between albumin and saline, but there was a huge difference between either of those and giving no fluid bolus at all. In fact, the mortality in the saline or albumin 20 ml per kilo bolus at 48 hours was 10%. It was only 7% in the no bolus group. In other words, for every 30 children with sepsis that you gave the APLS standard treatment, you killed one. The number needed to kill was 30. Now, there's lots of, I'm not going to go into the reasons for this, but most people would suggest that one very significant part of the reason for this is the high-tech stuff that we have in the global north, that we have access to inotropes and ventilators and oxygen, that we can recognize problems early and treat them. And so you can't just apply what we do in the global north in a high resource setting to a low resource setting. We can't just do the same thing. We need to be doing what is appropriate, the right emergency medicine for that context. For those who are interested, this study was effectively replicated in adults with HIV in Zambia as well. The mortality difference was even greater. It was a number needed to kill of about 7. So there is growing evidence for appropriate resource-poor setting emergency medicine. And that paper on FEAST was available for free. It was open access. But this one, ironically, from the BMJ about global health and about how global health is needed because it's equitable and it gives everyone benefit, that would cost 10% of a Rwandan senior doctor's monthly wage. And so the access is limited. So we can create publish all the evidence we like, but unless it's available, it's no good. Now, some journals waive their fees for low income settings. Some offer access via Hinari, but there are huge issues of equity and access. Now, one of the answers, of course, might be foam. We all use foam. I'm sure we all love our podcasts and our videos and the blogs we read. We use Life in the Fast Lane, and there's open access journals like the Hong Kong Journal. Or we've got used to Zoom conferencing, virtual conferencing like this conference, and we can make those free to people in low income settings. We've been doing resident lectures from King's in London to the residents in Kigali. These are amazing tools. These are really valuable and options for you to use in your training of doctors and nurses around the Asia Pacific region. You can now do virtual teaching, and it is great. But there is a potential problem. We've already considered that much of the actual content isn't appropriate for the setting that we're teaching in, although it's getting better. But what about the bandwidth? What about the tech availability? Many of our doctors in Rwanda are accessing their internet on mobile phones, on 3G, with a very dubious signal. Their hospital Wi-Fi dips in and out all the time. You can barely get a 5-minute conference before they lose signal. And that's going to be true in many of the areas of Asia Pacific, many of the poorer areas in Asia Pacific too. So does our, dare I say, obsession with foam and wonderful videos and streaming video conferences, does that actually embed a priority for high income settings who can access the latest tech and the latest videos? Now, one might also add that there's an issue of the cost. There's an issue of us being there. Let's just quickly go over this aspect of being there. We'll come to the cost in just a moment. None of us only uses foam. In your emergency medicine training programs in Hong Kong, you're there with your residents. You have actual FaceTime with them, whether it's bedside teaching, training them in POCUS, whatever it is. None of us just relies on the video stuff. We have to be there. And if we're going to be training people in emergency medicine in low-income settings, we've got to go there. We've got to get our hands dirty and help. And so we've come up with this little mnemonic of FAME. it's not just about open access. It's about freely accessible medical education that is appropriate. That is, it's the right medicine. It's available. It's there for them. It might be online if they've got the bandwidth, but actually it may need people in person connecting with them. And it doesn't have to be free. It needs to be affordable. Providing free stuff is often a luxury for rich people. If my Rwandan colleagues produce educational material, they need to be paid for it. They don't have the luxury of just producing stuff for free, which, let's be honest, many of us do in UK or Hong Kong. So freely accessible means appropriate, available, and affordable. What kind of in-person training could it be? Well, the basic emergency care course has just been launched by WHO. There's basic DHS run out of CUHK, which I had great fun teaching in Rwanda. There's the ATTACK course I mentioned. It's primary trauma care, which is the trauma course that's being run in those blue countries on the map. Residency programs, exchange, all sorts of opportunities for in-person training. And FAME includes all of that. But I'll finish with this final question. Who is teaching whom in those settings? Who is teaching whom? Because the assumption has often been it's us teaching them. And I've kind of deliberately used that language through this presentation, that we are going there to teach, or we are using virtual conferencing to enable them to have learning. But first of all, most emergency medicine teaching is now indigenous. They're teaching themselves. This is this is an infographic from Ghana, where I've just been. They've had a residency program now for 10 years. And they're now embedding that emergency medicine training throughout the whole of their medical education, undergraduate, house officers, clinicians or medical officers, as they call them, and then the emergency residency itself. So let's not imagine that it is us teaching them. Very often, there will be specific needs for some help. It may be in getting it started. It may be in some specific areas of training, like we were just doing workplace-based assessments. But I don't need to go to Ghana to teach them how to do ultrasound. They've got more ultrasounds in their department than I do, and they're much better at it than I am. So actually, there's a huge opportunity for us to learn from them, not just the humility of realizing that we have something to learn, but there is a huge amount of clinical stuff we can learn. So I started with the idea there's mutual benefit. There's lots of good things that we learn when we go to teach. But we took that one step forward, one step further with our EMIT course, Emergency Medicine in the Tropics. We ran it a few times. We're hoping it'll run again this year. Obviously, we couldn't do it in 2021 because of COVID. It was a 1 week, a 2 week course initially for small group teaching, 10 to 15 doctors from high income settings taught by clinicians in Rwanda. We had a program of lectures, small group discussions, but mostly focused on clinical bedside teaching, case discussion, and ultrasound and visits to district hospitals and cultural engagement. Why did we do this? Well, it's part of this vision of global EMT, of mutual interdependence in teaching. It was an opportunity for high-income doctors to learn about emergency medicine in a low-income country setting. It was an opportunity for those doctors to teach them, not just to raise the profile of the Rwandan Emergency Care Association, but to give them that sense of pride and ownership that they had something to teach people from Britain or America. And it developed networks, and it raised lots of money for them. It raised them about $5,000, about a consultant salary each time they ran that course. And I think that could be reproducible in Asia. It would be great if similar kind of courses, EMIT Vietnam, EMIT Laos, could be run. We published this in Education for Health, which was how we developed our curriculum for the course. And I know many of you are already involved in training programs. So why not start a course? The small group teaching for doctors from Hong Kong, Singapore, Taiwan, to go and learn emergency medicine from people in low resource settings. So teaching emergency medicine in developing regions, it's all about equity, interdependence, mutual benefit, but it does need to be the appropriate emergency medicine. It's not just phone and Zoom. We need to be there. And it's not just us teaching them. They have much to teach us. Thank you for listening to me. Sorry, I've slightly overrun. Happy St. George's Day. I'm sure Professor Graham is celebrating that with gusto. And there are the links for some of those resources that I've mentioned.
Thank you very much, Charles, especially for talking to us live straight after your plane ride and your long journey. And thank you for giving us the idea. I think for all of those from the Asian Society joining us, I think having the Asian version of Emit would be a great idea. And happy to hear any thoughts or suggestions. I think that would be great if we can do that. Time is short, but I think we can have one question. Kate and Vincent will be talking to us about BASIC and the MSF version of training critical care, intensive care in low resource setting as well. So I think that's a good follow on from Giles's talk. I don't see any question in the box, but maybe I can, yes, please go ahead.
Very briefly, happy St. George's Day, Giles. Welcome back and thank you. One criticism that's often made in response to your comment, we need to be there, and I do agree with you, is that we often drop in and disappear again. And as you said, the perception is that the benefit is actually for the trainee rather than the receiver of the information, so to speak, in the traditional model. Is there how do we deal with that? I mean, is there a place for long-term attachments, long-term virtual attachments? Is this where things like Zoom and, as you said, teaching from a distance, or maybe a better term might be interaction from a distance, might be the way to avoid that criticism?
Yeah, that's right. I think two things. I think, first of all, we do need to be honest and recognize that our motives are mixed. We do whatever we do, not just for altruistic reasons. There are things that we gain from it, whether it's just that experience or just the fun of going to a different country. We've got to be honest about that, and not pretend that we're this sort of great, noble person who's going. And I think and so there is mutual benefit. It is interdependent. We just need to let's be honest about that. That was my first thing. And secondly, absolutely, it's an ongoing, it's maybe relationship rather than just interaction, because what we want to do is develop a relational training that enables actually things to be two-way. As you really get to know people, you'll learn from them. And it may be that you set up a formal kind of Emit thing, but as you keep going back, as you get to know them, you show by being there and by returning, you show that you care. Theologians sometimes call this the ministry of presence. We could do everything remotely. We could do things from a distance, but actually by being there, by getting your hands dirty, by being sort of incarnational, if we're going to use theological language again, you are showing that you really care. And that can go both ways as well, because we can invite them, and we've got the funds to pay for it. We can invite them to come and do observerships in our settings. And that's a part of the ongoing relational training, which I'm hoping to see more from from our end at the Royal College, but places like Ghana, to try and get them over for a month observation. Vice versa, it'd be great. But you're not going to do that unless you have kept going back and showing that you actually care.
Absolutely. And that then brings real meaning to the word global, as opposed to what some of our other cousins say, international, because it really should be global in an inclusive sense. Thank you.
Thank you, Colin. Thank you, Giles. That's a great start to further discussion on training.